Hello, Johan. How are you?
Hello, Stefano. I'm fine. Yes, doing well, and seeing forward to to come to Colombia in a week and a half already. Yeah,
For everybody that is looking at us, I have the honor to be talking with Johan Lambeck. He's a physiotherapist from the Netherlands but teaches across the world. He's the co founder of the International Aquatic Therapy Faculty and the first non American aquatic physical therapy professional receiving the Excellence in Aquatic Physical Therapy Award by the Academy of Aquatic Physical Therapy, recognizing exceptional research, dedication, and his contributions to the field of aquatic therapy. He has taught over 900 seminars in almost 50 countries. Thank you, Johan, for accepting this invitation. And so, please tell us a little bit about yourself and how did you get involved in aquatic therapy?
yeah. First of all, I see I have to update my CV because actually recently I was teaching in Egypt and they asked me how many countries, so I started to count and I came to 55 countries already. Um, but anyway, yeah, quite an amount. Yeah, Well, my history. I was a swimmer as a boy. I always liked to swim. Then I started doing physiotherapy at the School of Physiotherapy in the Netherlands somewhere. And at the same time, I decided to become a swimming teacher. That's a small education, so it wasn't so difficult. And this came together in my thesis that I had to write. Then it was about swimming for children with a CP. And when I studied literature, I found an article about Helwig, and that seemed to be a very interesting method. Well, I was asked then to start working in a youth rehabilitation center in the Netherlands as the leader of the aquatic therapy department. I mean, it wasn't there yet. I had to make it. Um, and So then, quickly afterwards, I asked my boss if I could do a course in Helwig, yeah, because once again, it was interesting. It took me about 2 years to find James Macmillan, the founder of Helwig. And At the moment, he was living and teaching in Switzerland, in Bad Ragaz, from this Bad Ragaz ring method, also teaching at an educational center, but he just left there. And so the only possibility to learn something was to invite him to come to the Netherlands. And so that's something that he did in 1982. It was already. Um, and yeah, there was a success because actually everything that he told, I mean, by now a bit outdated, but at that moment not, was new and was also fitting with neurology of the day. And so we decided at a university of Nijmegen, that's a city in the Netherlands, to organize a conference that happened in 1986, where actually the neurologists that we had invited to talk about water said, well, um, from theory, we can imagine that going into the pool is very important for the human being and especially for the brain, of course. But they said there is no research. And later I had to continue telling this in courses until about 15 years ago when the first brain research in aquatic therapy then started, actually confirming the theory of 1982. And yeah, bit by bit, I met people and did courses and increased my network and started teaching myself, etc. But I think that's enough because otherwise I can talk for I don't know a couple of hours maybe about all these years of working and teaching and also research that I'm doing. Yeah.
Could you explain the difference between haloic and water specific therapy and how was its development?
Yeah. That is a nice question, and actually, it already started with Macmillan himself. So then, I have to go back to 1950 when Macmillan, as a fluid mechanical engineer, um, in his free time, was a swimming teacher in a swimming club in London, and in the same area was a school for disabled children called Helwig School, and so they decided to invite them for a gala just to meet them. So their goal was participation. And they had no clue what to do. So the children came into the water. Macmillan saw that they were losing balance, and as an engineer, he thought of some rules about mechanical stabilization. Inertia is an important word in this context. And they started to do games then. Then soon afterwards, the classroom teacher told Macmillan that the children, they had changed also in the class. They were sitting better, and so the famous words of Lambeck are that head balance increased, trunk balance, breath control, and also self-esteem. So actually, that was the beginning of what specific therapy, although not intended, because then I have to explain the difference between Lambeck and what specific therapy, although they are connected. Lambeck actually is motor learning in the pool. Yeah, and you're going to use this in the pool, so that means swimming and applications of swimming, like competition. And what specific therapy is motor learning in the pool that you're going to use on land on purpose. Well, Macmillan didn't do this on purpose. It was a kind of side effect. But it drew the attention of physiotherapists, first in England, and later, that was in 1963, in Switzerland, where he was asked to tell something about Lambeck for the Bobath Association in Switzerland. And then they asked him to work there. And with a group of therapists, they looked specifically on how to use elements of Lambeck in physiotherapy thinking. That means using the pool in order to solve problems on dry lands. And that became finally what specific therapy.
Is there enough evidence to justify aquatic therapy?
Yes, there actually is an enormous amount of evidence. I started collecting articles a really long time ago, and that had a boost more or less when for 10 years I was working as scientific assistant at a university in Belgium. So altogether that means that I still have a database of at least 5,000 articles on everything that has to do with water. And I think something like 80% is about patient treatment. So there's evidence then of aquatic therapy in actually all kinds of patients, in all kinds of methods. Then there are, of course, areas where there's lots of research, like osteoarthritis of hip and knee. And there are areas where there's hardly anything when you think about diseases that are quite rare. And the evidence has the same level of quality as every other research in medicine and physiotherapy as well. Practically, we have very good papers, and of course, we also have papers that are not so good. And I think it's important to say, because I hear that people, colleagues, but also doctors say, well, there is hardly evidence about aquatic therapy. That's completely nonsense. And the evidence is even as such, when you look at also the statistics, and I know statistics, so I think I can judge, that in many cases, especially when you talk about balance in posture and gait, aquatic therapy has better effects than dry land therapy, especially in patients with neurological diseases.
Is it necessary that they have a specific indication, or can we take all the patients in the water? And is that for everybody?
If you want, you can go with every patient to the swimming pool. But I give you an example. Once I was teaching a course where we had a patient with osteoarthritis of the knee, or a knee replacement, I forgot. And he was telling us, or me, that he already was walking around that city where we were in the mountains for something like 5 hours per day. And then his knee became a bit tired. So he wanted to walk actually 7 hours per day. He was a walker, etc. And we were in this very tiny pool of 3 times 3 meters. And then logically, what can you do in such a pool? Yeah, so no, not every patient, of course, is suitable for aquatic therapy. And the other way around, yeah, when somebody has enormous problems with gravity, yeah, that means always falls, has a very poor trunk balance and head balance, then logically the support of water, yeah, may help to overcome that problem, hopefully at some moments. When dry land gives lots of pain, then aquatic therapy could do something. When there are more there are more of these examples, but a very nice example perhaps also is something we don't realize so much, and that is quite new. If you have problems with your intestines, then aquatic therapy may also be of help. And that's a bit difficult to explain, but because of COVID, yeah, we know that viruses can change the bacteria in your intestines enormously. Yeah? It's called dysbiosis. And we also know that going into the pool increases activity of the intestines, so the peristaltic activity. And there is a little bit of research now that shows that is better for this microbiome, for this bacteria in your guts, than doing things on land. The same if your patient has enormous sleeping problems. Also, then aquatic therapy may be of enormous help. But these are two topics that are rather new, and I would like to mention this anyway, because everybody always says, you go into the pool when your muscles are weak, when you are spastic, when you have pain, when your range of motion is not good, the classical things, and that's logic. So the range of indications is in fact quite wide.
In general, we see that passive methods are used most of the time, or maybe we offer too much assistance. Is there a systematic approach that we have to follow, and which methods are there to treat patients?
Yeah, look, for most of the patients that we work with in physiotherapy, and these are the patients with neuromusculoskeletal diseases, adult or child, we know that the topic that we want to address, is motor learning. They have to learn too, and then you can fill out what you want. And that learning, that logically must be active and cannot be passive. So for the majority of patients, you have to do something active. That's one. Secondly, we know now that activity has to have a certain threshold in order to change the adaptation of a tissue. That can be a muscle, it can be connective tissue, it can be brain tissue, but there must be a certain threshold. And practically, the threshold is quite high in many cases. And so you really have to be rather active, if not very active. One could say patients have to get tired during an aquatic session. If not, you have not trained the system well enough. And that means, of course, that some of the methods that we use are not so applicable. All the passive methods as I used already, as I mentioned already, and that in methods like, for instance, water-specific therapy that we mentioned already, you have to include these physiological parameters. And well, water-specific therapy, the core business is postural control, posture and gait, as I said. And Badregat's ring mat is another one. And that core business is strengthening of muscles in myofascial chains. Yeah, we have clinical IG, and that's another method that we teach in IATF, and that actually is also focused on balance in posture, and there is no gait there, balance in posture. with elements that, say, belong to balance, adds another level of therapy thinking when I refer to the International Classification of Functioning Disability and Health.
When we look at small videos on YouTube, we tend to see a choreography of movements without any kind of clinical reasoning or background reason to do them. And some therapists, when going to courses, sometimes want a kind of recipe to solve the problem of a patient, like, for example, 10 repetitions of flexion extension of the knee. Is there a specific dosage that we can follow with all the patients?
Yeah. Look, when we stay with the knee and the knee exercise, actually it's a nice example, but there's very good research about the doses or the intensity that you need to achieve. So in order to work at the intramuscular coordination, let's say the intramuscular coordination of the quadriceps muscle, you need to have a speed of something like 170 degrees per second. That even is positive for cartilage, at least a part of the cartilage, according to research by one of our AATF colleagues, Ben Waller, in patients with osteoarthritis of the knee. So 170 degrees per second, or let's say make it 150 degrees per second, that is very fast. When you look at flexion extension, which something is like 60 degrees, well, when you do it a little bit fast, then it would mean that you need to have 2.5 cycle. So flexion, extension, and a half a flexion in order to achieve that minimal doses. And indeed, that is something that often you don't see at all in internet and YouTube films. So, and that is something that we try to tell the world also in IATF, that physiotherapists must use the rules of training of tissues, because otherwise nothing changes. Patients are always satisfied, whatever you do, because they don't know. But this is not according to the ethical and professional standards that we have in international physiotherapy.
So, based on this, it's important to think of the exercises that are challenging enough to produce adaptations and use measurement tools that are related to the exercises, what will be related later in our results and will eventually justify our services. Do you think that it is important to follow a line of thinking based on what the patient needs, our experience, and the external evidence to support our clinical reasoning, or just by going into the pool and raising the leg up and down, it'll be enough?
Yeah, absolutely. The patient has a health problem and trusts that we, as physiotherapists, are able to help them in the most effective and most efficient way, based on what is known at that moment, at the state of art there. And that's hardly ever happens. Hardly ever, I cannot say. It depends a bit on the country also. Yeah, I know that some countries in Europe have high standards. Australia has high standards. Canada, United States, depends on the state also. Of physiotherapy, including all the topics that you just mentioned. One of the cases I normally use in the course is a patient with multiple sclerosis, who has a paretic leg, so it doesn't work very well. It's not that spastic, and the assessment shows that there is a problem with muscle activation. Well, actually, he has 4 problems. One is that he's not able to weight bear for a while when he's at the workplace in the kitchen, for instance, when you just go from one leg to the other. And he would like to do this for 10 minutes, 50 minutes to prepare a meal. And then that doesn't work because the knee gets tired. He has difficulty walk stairs because he doesn't have the power to walk the stairs or walking or step into a bus, for instance, a high step. He is afraid to fall when he is amongst people, like on the market, because he is not fast enough for a stepping reaction, so a stumble step. And then after about 150 meters of walking, he has a drop foot, and also there the quadriceps is getting tired. So actually, he talks about 3 or 4 different kinds of strength, which logically then you cannot train with only one little knee exercise, flexion, extension, with a certain low speed. And that is typically what you can find on YouTube, which is a shame.
Sometimes when we are working with a group of people in the pool, everybody tends to do the same exercises, but it's important to have a therapeutic goal for the specific problem of each patient so we can approach their needs the best way possible. So even in this case, it's important to try to keep updated and adapt our exercises, but always having in mind that we have to relate them always to the evidence. And if we need to, we can always refer to a more experienced peer.
Yes, of course. I mean, but that is not new. I used to work in this rehab center, which is now meanwhile over 20 years ago, and we did exactly that. We tried to be specific, with the knowledge of the time, of course. We had specialists and generalists, so there were some people that were very good in manual therapy, and I was a specialist for aquatic therapy. Now, every colleague would do it, but if there was a certain insecurity or they couldn't find a good exercise, then they would come to me, and otherwise they would go to the manual therapist. There was something manual therapy to be done. So for this, you cannot just be an aquatic expert when you work in the pool. You have to educate yourself. You have to be critical with yourself. And you started with saying that exercises are specific, and yes, they are. And also that is not new. Already 30 years ago, it was clear that if somebody has a problem with standing, then walking exercises will not support that standing problem so much. And when somebody has problems in walking, you have to walk, then standing doesn't work. And I have done the old-fashioned bow bath or NDT courses in the past, where we were very careful. And then also in weight bearing, we didn't want to have too much tonus increase, etc. And finally, by now, research says that we were treating, in fact, learned non-use, thereby not asking patients to be much more active, perhaps with a little bit spasticity in the hemiplegic leg. And in the pool, I still see the same, and that is, you go to the pool, and the first idea is, okay, we have to be careful, we pamper the patients, etc. And no, we have to take our whip and make the move.
Talking from the rehabilitation point of view in children or patients with neurological diseases that are confined to a wheelchair, we forget that they need to move and feel free to be as active as they can. We tend to forget that water helps us facilitate functions that otherwise will be difficult to accomplish on land. We just provide too much help, limit the capacity that they have because they are not normal, or maybe use a relaxing approach when setting our treatment goals. What do you think about that?
Yeah, that's completely nonsense. Everybody in a wheelchair has a limited capacity of the cardiovascular system, and has a limited capacity of recruiting muscles faster. That's power, muscle power. The capacity of the cardiovascular system is both aerobic and anaerobic, and in both cases, and this finally, this limits the participation of the children, not the fact that they are a bit spastic also. For this, we have medication in case it's necessary. So relaxation Why? And children need to move. They want to move. And for this, they have to sustain the games. They have to sustain the day. And that is something that you don't get with relaxation. That's something that you get with training and playing and moving and swimming and etc. Then the physiotherapist comes around the corner and says, would be a little bit careful, not too much stereotype movements, see that there is some variability of practice, in order to prevent that, let's say, networks in the brain becomes too fixed. You want to have some synaptogenesis. Okay, these kind of theoretical backgrounds. Then once again, relaxation. No, not only.
What would you recommend for those patients that are fixed in their so-set pattern of abnormality? Because we tend to try to avoid them, and by limiting their unwanted reactions, we also limit their capacities or possibilities to do an independent activity, even if it is just in the pool.
Yeah. Anyway, those patterns will not change so much when you think about neurology, specifically of a stroke. After a few months, pattern is relatively fixed. So actually, it's much more important to train the healthy leg also. That is something that they say 100 years ago, and then it was no. Of course, you should train the affected leg. But bit by bit, we know now that the normal leg need to be trained also, because this affected leg is not doing so much. So there is this asymmetry that you don't change. Well, then, of course, then somebody is a bit slow. There is an increased risk of falling. And that is something that you can nicely train in the wall and in the pool. Not that asymmetry changes, but once again you increase power. Jumping is something that many people like. When I ask at the end of the session, when we have done many things to adults, what do you want to do again? Say, jumping. Here I can jump. Then. And jumping as a plyometric exercise is also used to say something about agility. And agility is the ability to quickly move your center of gravity through space. So quickly move through space. These are the key words. And I call this aquatic self-efficacy. And so that's the feeling, at least in the pool, that you're able to do something. You have the world in your hand in the pool. And that may help with resilience also. Knowing that in the pool you can do all kinds of things. You have less pain. You can run. You can make tumble turns, maybe, who knows. And on land you're limited. But when you have a compensation, it might also be very important. And that's something that's, it's good that you touch on it. Because indeed, therapy is much more than only thinking about 10 repetitions or the range of motion of a joint. Of course, now they find out that you could address the human being as a biopsycho social unit, which is not new. I mean, that is something that I learned when I was educated over 40 years ago. That other topics are also important. And the pool is a place where it's easy to meet people, where you can touch people, and where you can be yourself again, where you can also be with peers that have the same problem, and where you say, I cannot do this right now, but he can already do this, so maybe in a few weeks I also can do this. And playing, of course, is a very important topic. It's a basic human behavioral tool that we should use. And that's also then what more and more in our courses we go to. It's called, we call this aquatic gamification. Then where actually the two words are move and think at the same time.
In some rehabilitation centers, we can see a group of people kind of doing boring exercises in the place where they are standing because of space limitation, when they could be playing with each other, having fun, of course, without forgetting the clinical reasoning to set a specific goal with each of them. Is there evidence for this kind of approach?
And yes, of course, no, there's lots of evidence about this. If you look at the literature of Parkinson, for instance, then one of the topics that always comes up is let them dance. Dancing, yeah, is much more important than physiotherapy. So you can dance in the pool if you wish. But then you have to combine it, of course, and that is you have to play, but it has to have a goal that is important for the patient. That came out because of the assessments that we did as a physiotherapist with the patient. And of course, another topic is that we want to have the patient to keep training, to also come back logically. So compliance is much higher when somebody is doing something with intrinsic motivation. That means I like it. Then when the therapist says you have to do it. And so there is this Japanese colleague who published an article about two groups of elderly in the pool. One group was doing boring exercises, like the knee 10 times up, flexion extension, 10 times abduction, adduction, etc. And the other group was just playing then. And they looked at executive functions. Actually, the software underneath your sensory motor software, decision making, concentration, other solutions, finding other strategies when something doesn't work. And this software, so these networks, were way better addressed in the people that played than the ones that did the boring exercises. For this, sometimes it's better to have a psychomotor therapist or a physical education team, physiotherapy, because these people have much more fantasy. And I was lucky in the time I was working in rehab and also afterwards, but especially there to work together with all these people, including kindergarten teachers. I mean, they have lots of fantasy to do things with children. So I know lots of children games from the Netherlands and songs still that also then can be used in groups of elderly, especially women, because they are grandmas and they also sing the songs again with their grandchildren. And then, you have to adapt it in such a way that the woman with rheumatoid arthritis, finds it important, to move again and has joy a little bit in the body that otherwise is hurting. Therefore, whatever you do, you must keep your goal in mind, and it must be effective and efficient to reach that goal. So goal setting is a very important topic then, of course, and then you should also know what you could expect of a certain intervention in, let's say, 2 or 3 months. Take something simple like a time up and go. When somebody comes with a time up and go for the first time and he does 15 seconds, and after 3 months of hard work, you do 14 seconds, so 1 second better, than everybody will say, well, nothing happens. But if you do 12 seconds or 11 seconds, you say, well, 4 seconds, that's a change. And then you have to know if this change is clinically important, yes or no. So then, the knowledge of assessment, a little bit of statistics, come also to that. And then lots of colleagues, they say, okay, thank you very much. I go drink a beer.
Is there something that you would like to add or address to young physiotherapists that are just finishing their universities? And also tell us where can we find more info about the courses that you've already done?
Yes, of course. And there is, don't forget the pool. And logically, everybody will say, but you say this because you are in the pool, so to say. But once again, the literature is overwhelming. That's aquatic therapy in many cases has really better effects on patients, and then especially, and I repeat, and the balance and posture and gait, which basically is something that we use every step of daily living in lots of patients, and especially in neurology. And actually, the statistics there, say something like, if you don't go into the pool with your hemiplegic patient, you mess your patient up. He should go into the pool. So that's a message for the young physiotherapists, that they should not only think about the wonderful machines that we have on land, of the wonderful manipulations that we like to do, but also make people move, because finally this is what we want, what everybody wants. So independent movement, and if you're a bit spastic or not, as long as you're independent enough to cross the street, safety is much more important than have 2 degrees more of extension in your knee or another joint then. Yes, of course, I hope to see quite a few people. We have a history of courses in Colombia, and I guess the testimonials were good. And if people want to see testimonials, they have to go to our website, that is hellewick.eu or hellewickTherapy.org. You find testimonies, of course. It's testimonies about me, so people can see if either me or IHF is attractive enough to come. But we think so, because yes, we have taught in many countries, and that's not for nothing. So I think that we teach things that are important for patients, are important for physiotherapists.
I want to thank you, Johan, for accepting to do this interview. It was a pleasure as always to listen to you. So now we just have to wait until March to see you again. Thank you.
See you soon. Bye-bye.